first thing I'm going to say is that the notion that addiction is a brain disease is a relatively new notion. This is an article in 1997, and it talks about the fact that in the last 20 years, and this is again 1997, saying we've started to learn a lot about this disease of addiction and how it is that it affects the brain in a long-term way. So what we know now, we're going to know even more 20 years from now. You are going to see some pictures that have a lot of brain and neurotransmitters, and you're going to be fine. Everybody in the room is going to be able to handle this one. I'm going to spend most of my time talking about dopamine. I spend a little time talking about some of the other neurotransmitters. And one of the reasons I'm showing you this slide is there's 3 parts of the brain that get very impacted by drug abuse. And I'm not going to spend my beginning talk on opiates because the disease of addiction is addiction overall, whether it's an opiate, whether it's alcohol, whether it's nicotine, whether it's sex, whether it's sugar. It actually often works the very same pathways in the brain, okay? The ventral tegmental area, the nucleus accumbens, and the prefrontal cortex are the places that are chasing each other when it comes to addiction. And I'm going to be dropping those words. I just wanted you to see it on a sort of cartoon of what a brain might look like. This is the real cartoon of what a brain looks like. The part of the brain that gets broken with addiction in general is the nucleus accumbens. It's what I think of as the lizard brain. It's the thing that says, run, fight, get laid. That is the part of the brain that gets broken. So this is the part of the brain that makes you want to eat, makes you want to look for clean water, and makes you want to have sex so you can continue your gene pool. This is the most ancient part of our brain that drugs interact with. That's the problem. It would be way better for all of us if drugs attacked some part of the brain that didn't matter so fundamentally for your survival. This part of the brain has, you know, we've been on this planet for 200,000 years, and this hasn't changed much in that time. Your whole point 1,000 years ago or 10,000 years ago was to survive, right? You had to find food, you had to find water, and you needed to find a mate. That was the point of it. The problem is that when it comes to drugs, that attaches itself as strongly to this part of the brain as the other driving urges of being a human. The cortex, which is the slowest thing to develop, particularly in the teenage brain, that is the nice, smooth, put on the brakes, listen deeply, have patience, make respectful boundaries, all these sorts of things that teenagers just don't do. And that's because that part of the brain isn't developed yet. I actually love this slide here, and I don't know how well in the real back you can see. Can you guys see colored lines at least pretty well? Okay. So what this one shows is initially, and do I have a pointer, do you think? Is this a pointer? Maybe not. What you see is there's prenatal development of the brain that happens in utero. And in the beginning, when you guys do an ultrasound on a 6-week or a 12-week embryo, what you really see is you see this giant head and this little tiny body, because the brain size, the volume of the brain early on is huge in comparison to the body. And the volume quickly drops off and you get a normal-sized brain. The 2 parts that are not done developing in adolescence are 2 critical parts. And one is myelination, okay? And that is continuing until you're age 24, which is why everybody, when asked, when does the brain stop developing, it's age 24 or 25. Myelination is when you are insulating axons or transmitters between parts of the brain. So myelin is this nice big fatty insulation that covers it. That is happening in this critical way during adolescence. The second thing that happens during adolescence is synaptic refinement. You have billions of cells in your brain. You don't need billions of cells. That's a little over the top. You need fewer than that, and you need to figure out during adolescence what stays and what goes. And you can imagine an adolescent that's full of chaos and trauma and stress and misery and depression and anxiety. The way that they are refining the synapses in their brain is not as healthful for long-term well-being than somebody who comes from a really stable, wonderful home where they have plenty of food and the heat is on and their clothes are clean and they go to a lovely school and they get an opportunity to learn. So these 2 critical things are happening during the adolescent age, and you can't imagine, and I think a lot of people do imagine, these kids are cooked by the time you get to them, but that's not the case. These kids' brains are plastic. They can go and get better, or they can go and become very, very ill. I promise not many PET scans, and this isn't actually a PET scan, but I am going to just remind you that the prefrontal cortex and the cortex in general is the last thing that gets developed. So what you see on the left side of your screen is starting about the age of 5, going till about the age of 20, and then beyond. As things turn more dark blue on the brain, that is a more developed cortex, or the outer layer of the brain. So what are the implications of incomplete brain development in an adolescent? Well, the implication are these 3 boys who are absolutely doing something I don't think they should do. So it's act first, think later. More risky, impulsive behaviors, less than optimal planning or consideration for negative consequences, and a very strong preference for physical activity and sensation seeking. That's what teenagers do, right? That's why they're both awesome and they're terrifying. People are parents of teenagers in the room? We got a few, right? Okay, this is a lovely slide, and this is, again, I'm not going to torture you too much with how things are moving in the brain, but there's 2 neurochemicals I need you to pay attention to. One is serotonin. Everybody knows about serotonin, because for those of us who've ever suffered with anxiety or depression, in general, your serotonin levels are on the low side. And serotonin has a big impact on mood, on memory and memory processing, on your quality of sleep, and on your cognition. So when you're working with somebody with depression, they'll say, I live in a fog. I just have this molasses brain. My sleep is terrible. My mood is terrible. And they don't have enough serotonin hanging around. And that's why the selective serotonin reuptake inhibitors, for some people, make a difference. That's that class of medicine we use for depression most often and for anxiety. It allows serotonin to hang out in the synaptic cleft a little bit longer, which is what we needed to happen. Dopamine, on the other hand, which is where we're going to spend most of our time, is the chemical that's getting released from both the ventral tegmental area and the nucleus accumbens, and that is all about making you feel awesome. It motivates you. It gives you reward for behaviors that you do, including finding water, finding food, having sex, right? But then it does a whole bunch of other things that can trigger more or less dopamine to get released. The part of this brain triggers compulsion and triggers perseveration. And you want that to happen. When you were alive 10,000 years ago, you needed to perseverate on finding food, water, and sex. That was the focus of your entire life. That makes total sense. Whoops. But you can imagine if this part of the brain is broken, that perseverating on how to get your next fix starts to take over for everything else. People will go without food, water, drink, human contact, love, connection to other human beings, because that part of the brain is all about getting the drug. And I don't care what the drug is. We're talking about opiates. It's a very powerful breaker of the nucleus accumbens, for sure. But it's very hard to let go of that drive. It's not a weakness of will. It's not because they're bad people. This part of the brain, this most ancient part of the lizard brain, is no longer functioning normally. So this is me. This is me because in general, I'm a really happy person. I've had a glorious, gifted life, and I, in general, have really high dopamine levels. I walk out into the world and I really see a blue sky and beautiful green trees, and I can smell the lilacs, and I feel hope almost every day. My dopamine levels are probably a little higher than average, is what I think. We don't measure dopamine levels. We don't have a way of doing that. Someday we'll get there, and I tell you, that will be a very useful thing to know. Because I'm going to tell you that on average, our dopamine levels are maybe 100. I'm arguing that I may be sitting at 110 most days because I feel pretty good. The problem is we know a lot of people who don't feel like this. They feel like this. These people's dopamine levels at a baseline just aren't very good. They may be 70 or 80. Some of them may be 50. And I have to say, most adolescents aren't feeling like this, right? In general, a lot of adolescents are all over the place, as you know, and many of them are feeling pretty rotten on a given day. A middle school, who wants to go back to middle school or high school? Anybody? And you guys live there, right? You guys did somehow go back. But these are hard years for many teenagers and young people, particularly if they're coming from households that are dysfunctional or communities that are dysfunctional. Okay, ready for the next slide, because this is the most important one in terms of really getting why it is that these drugs work so well. So Baseline, if you're at 100, and then you have like the best piece of flourless chocolate cake with a little raspberry drizzle or something, you get yourself up to maybe 150. You have sex, that's awesome too, you may get to 200. You use cocaine, you're at 350. Opiates, heroin will bring you to 500 or 600 level. Methamphetamines, crystal meth, 1,200 to 1,300. You know, why wouldn't you do it? What's amazing to me is more people aren't using heroin, particularly if you felt terrible all the time. If you could get yourself to a 400, a 500, or 600 most days, why wouldn't you, right? It's great. But as we know, it doesn't last long, because the brain, which will manage 150 or 200, because its whole job is about getting food, having sex, finding water, making connections to people, bringing you up to slightly higher dopamine levels so you'll continue that behavior. When it gets to 300 or 500 or 1,200, the brain's like, holy smokes, something is wrong here. These are not normal levels of any hormone or any neurotransmitter in my brain. Something must be off. I need to tune it down. It's like a radio being really loud. I need to turn down the volume. So I'm going to just show you, this is the way that cocaine works. So there's a transmitting neuron that's releasing dopamine, and dopamine sits in that little cleft, that synaptic cleft, and then there's little receptors that suck up the dopamine, and the message has been sent. That's the way it normally works. The way that cocaine works is it turns off the recycler. So dopamine sits for a longer time in the synaptic cleft, which is awesome, right? If you want to feel high or better or whatever it is that you're going to get off cocaine, that is the way that drug specifically works. So all the drugs do one of the following three things. They either make more dopamine, they allow dopamine to sit there longer, or they increase receptors for dopamine so more gets absorbed. Okay, so that's almost every drug I'm going to talk about will do one of those things. Okay. The problem is that when the brain is seeing a 300, a 600, a 1,200, it says something's wrong, I need to turn somebody off. Either I'm going to stop producing as much dopamine, I'm either going to increase my number of recyclers, so I'm going to suck it all up as fast as I can because clearly there's something wrong with this brain, or I'm just going to down-regulate my number of receptors. I'm going to get rid of receptors. It does not take long for this to happen. It takes 3 to 6 to maybe 9 weeks for us to start to see this with the opiates. So normal brain is in that first little graph that's on the upper left, and there's a baseline. You have an orgasm, it goes back to baseline. When you use drugs, you start off at a baseline, you get wicked high, you feel fabulous, and then you return to what your new set point is for your new baseline, which isn't a dopamine of 100 or 110 where I live. It's not even a dopamine of a slightly depressed person of 70. It's a dopamine of about 30. You feel awful. It is hard to get out of bed. This is not about feeling drug sick because you're withdrawing. Your brain is broken in a way that you can barely function. You're unpleasant to be around. You're screaming at my front office staff. You're throwing an F-bomb at me. That's the way you live. Nobody wants to be this. And if kids understood that these drugs make you feel great for a little while and then they break your brain, if we were really able to teach them this, I think a lot of kids would be like, yeah, wow, I'm not so interested, right? It may not be worth it. But nobody understands this. Nobody talks about it. The Just Say No campaign in the 1980s, not so effective. Because guess what? Kids are wicked smart. It doesn't make sense to them to hear, just don't do it. Like, why wouldn't you do it? I explain this to my 9-year-old. I sit down, I show her these same slides, I tell her, this is the thing. It makes you feel good for a while, and then it really stops making you feel good. So, broken brain, that little bloody bandage is sitting on top of the nucleus accumbens because that's what breaks. I give this talk to doctors, I give it to judges. I give a slightly different talk to them because I launch off now into this place that really goes into sort of why do people treat this disease differently than other diseases? My next slide on a different talk I give shows the transmitters that happen with diabetes, type 1, type 2, because the average judge may not know how that works. But the truth is the pancreas gets broken or the insulin receptors get broken with that disease too. There are broken receptors with cardiovascular disease. Almost every disease in your body other than infectious disease is governed by these same mechanisms. Transmitters get broken, receptors get broken, or there's a decrease in the amount of the chemical that's involved. So the notion that this disease is any different than any other disease out there makes me insane. But the average person doesn't believe it. The average politician, the average doctor, they are full of judgment about this disease. And that's why we have so few resources to help people get better. The average person that shows up in the emergency with, heart attack, that guy is getting swept in, getting, a cath right away, a stent, quintuple bypass. They're kept in an ICU for a while, and then on the floor, and then they have a social worker and cardiac rehab. Everything comes at that person. I can get all judgmental about that person too, right? They're fat. They smoke, they have a terrible diet, they have terrible genetics, they should have known better. Like, you want me to start judging other diseases as hard as we judge this one? I'm happy to go after it. But instead, let's flip it on its head and say that this is a disease where the brain breaks down, and we need to help those people in every way we can to get better. In our ERs, when somebody walks in there with an overdose, they keep them for a few hours. You want treatment? I don't got a bed for you. Bye-bye, see you later. The risk of that person dying at 30 days, 60 days, and 90 days is higher than that guy with the heart attack by a long shot. And you know what? That was a young person. The guy with the heart attack was 75. I'm not saying I'm judging anybody on age here, but let's invest the time and money in helping our individuals who have this disease. So a couple PET scans. So healthy subject brain is on the left. So that is showing dopamine levels in a normal person. And then on the right is somebody who uses drugs. So again, dopamine doesn't get produced. It doesn't get utilized in the brain in the same way. The next picture, same thing. It looks at different drugs: coke, meth, alcohol, heroin. The first column is a control. You can see a lot of orange there. The second column, there's very little orange. There's a little more orange with alcohol. Dopamine isn't actually always the chemical. It's the different chemical called GABA, which gets disrupted with alcohol. But in general, dopamine receptors, dopamine transmitters are broken. Okay. This is a very useful slide for everybody to understand. And so when Lieutenant Governor was talking about when should we be talking to people, addiction is an adolescent disease. There are very few people who will get addicted to their first substance after the age of 26. It's very unusual for that to happen. My exception to that storyline is there is a spike in new alcoholism in men starting like in the 60s, sort of at retirement age. Guys who never drank are like, oh my God, I'm home, my wife, she's making me crazy, I'm making her crazy, I'm gonna start drinking. So that is a second spike we will see, but in general, all addiction starts right here, everything. And let's look at those ages. So the ages start at 5, and up on this chart they go to 50, and then the percent in each age group who have begun using, this is specifically alcohol, nicotine, and marijuana. So the blue line is alcohol, the red line is nicotine, and the green line is marijuana. This is old data, 2013. I would argue that that green line is way higher now. But what you see is things start early, starting at 9, 10, and 11. So let's pause and say the words 3rd, 4th, 5th grade. People will start their first drug. Often cigarettes, right? Or I would say equally these days, often marijuana. And quite honestly, alcohol often will follow very, very quickly. And you can see, these are the kids who are under your care. Every one of these kids is this stuff, this exposure to these chemicals that are altering the way their brains function is happening in your schools. We all know that. Everybody knows that that is happening. But what does the average pediatrician or the average family doctor who takes care of kids know about addiction? Again, zero. This is a pediatric disease, and we have to make sure that people understand that if we can prevent it in this age, we can prevent it really for a lifetime. Smoking. All smoking starts before the age of 26. 98% of smokers start before the age of 26. Really, it's before the age of 23. You know what the legal age should be of buying a pack of cigarettes? It should be 25. You know what? I'm a believer in big government. I think big government drives public health, and we have to set limits. So that little arrow is the time when a conversation in our schools should be happening. very, very early, before their brain has been hooked on nicotine or the cannabinoid receptors are starting to freak out. Now, the next slides Kathy gave me, and they're very good and they have lots of information. What I'm really going to say is the comment that there's not good public funding for health education in our schools. Now, I don't know when the pipeline turned off on that, but I know that you guys are not getting funding for 3rd grade, 5th grade, 7th grade, 8th grade, 9th grade health education. These kids, you can talk to them about their brain receptors, but some of them, they don't even know what the brain is. They don't know what the lungs are. They don't know anything. They don't know how their bodies work. You have to start very early to build health literacy, and I recognize there's no funding for this, and this has to change. So when I say take this talk and bring it to your school committee, bring it to your superintendent, bring it to the people that set the budget, this stuff really matters. And I hate to say I'm sort of relying on you in this room to drive this public health intervention, but I am. I'm relying on you guys in the room because most other people don't have the skill set to do it. They don't have the audience sitting in front of them to do it. And I could tell you, the average doctor's office is spending no time on this stuff. This specifically looks at alcohol, which is where we have the best data on the teenage brain. 40% of kids who start drinking at the age of 15 will become alcoholics. When I say drinking, I'm not talking a couple 6-packs a day. I'm talking 2 drinks a week, not much alcohol. 40% of those kids will become alcoholics. That's shocking. I continue to be shocked by that slide right there. How many people have their alcohol locked up in their house? Is it under lock and key? Okay, not enough hands just went up. And I say this to you because in your house right now, there are bottles of pills. We all know that because we all got them. There's alcohol. And quite honestly, for the 6th, 7th, 8th, 9th grade crowd, they're inhalants, right? Because when we look at a next slide that's coming up in a little bit, those early middle school kids, they're huffing and snuffing and doing all kinds of things with any gas, volatile gas they can get their hands on. Our high-risk kids, tech school kids, because they're exposed to huge amounts of volatile agents. So you should look in your basement and in your garage and see what it is your middle schooler can get in trouble with. So I started locking up all the alcohol in my house about 2 years ago. I thought, you know what, I actually don't want my kids to drink early. I've had this conversation with them. You could start drinking when you're 21, when the rates become normal levels of addiction. But until then, you need to delay exposure, and I'm going to tell you why. This is a lovely slide that looks at kids who have a parent who's an alcoholic versus kids who don't. So if you have a parent who's an alcoholic, you have a 50% chance of becoming an alcoholic yourself. There is not a single disease you can name that has that level of genetics behind it, right? People are always like, oh, somebody had breast cancer in my family. It's like a 3% conversion rate genetically between breast cancer of you getting it and having had it in your family. Most of us who get breast cancer, it's de novo. It started with no family history. Addiction is very different. If you know that one of your parents suffers from addiction or you come from a family with a lot of addiction, you need to take that knowledge, you need to hold it tight, and you need to run away from drugs that could get you addicted. And I say that to my young people I take care of in my office. Sometimes I know their parents. Sometimes I'll just ask them, what's your parents' relationship to alcohol? And they'll say, kids know, right? They're like, my dad's a drunk. And I'm like, fascinating information, my friend. Let me tell you what I know genetically about you. I'm telling you that your likelihood of having trouble with alcohol is extremely high, a 50% likelihood. So right now, you and I are going to make a strategy, and we're going to make it every single year, how you're going to avoid that drug. And in fact, all drugs. Kids need knowledge, and you need to be able to give that to them. You guys often know when there's struggles at home. You guys know actually better than anyone else what else is happening in that household. So what that green line shows is that if there's a parental history that's positive, there's a much higher risk of having your own disease of alcoholism. If the parental history is negative, the risk is lower, but it's not zero. So again, drinking early, 13, 14, 15, if you don't have a parent who's an alcoholic, your rates of future alcoholism are still 20 to 23%. That's still a really high number. Once you hit 21, and is 21, is that why it's the legal age? No, of course it isn't. There was no sort of health reason for that. It just happened to be chosen. But at 21, your rates of becoming an alcoholic become normal. They're like 7%. Those are normal national statistics. 7% of Americans are alcoholics. It's a high number. Okay, so what are some good pieces of news out there? Everybody's covered this one, but cigarette smoking has gone down, right? That's a good thing. We're going to talk about that because that's actually a more complicated thing. But what this shows is over time, so starting in the 1970s is the data I'm working with here, you can see that in the 70s, a lot of people smoked nicotine, a lot of people smoked marijuana. Look at those numbers, 40%. That's a high number. And as time passed in the 1980s, marijuana use went way down, and then it's begun to creep up. And why has it crept up? It's crept up because, in general, 12th grade students have a much reduced sense of harm with marijuana, right? It's legal. Legal in Colorado, legal in Alaska, legal everywhere as far as these kids are concerned, right? You talk to the kids, they're like, this stuff is fine. No one's going to arrest me for this. So just watch the pattern there. Daily use in the 70s, high. Sense of harm, low. In the 80s, sense of harm, perceived risk goes up. Use goes down. And then as the sense or perceived sense of risk with the drug begins to fall, the use goes up. It will be on the ballot likely next year is our guess, right? Legalizing marijuana in this state for all consumption. Right now, medical marijuana is legal. You know, everybody always gives me that medical marijuana question at the end. You know, I'm going to launch a little bit into marijuana in a second, so I'll just pause for 1 minute. But let me say that the use of marijuana is incredibly high. Has that been your experience? People smoking a huge amount of weed in your schools, they don't hit like light up or vape or whatever it is that they're doing out there a couple times a week. We're talking 5, 6, 8 times a day. I wake up, it's the first thing I do. I do it throughout the day, I do it as soon as I get home, and I use it to sleep. That is a huge amount of marijuana use. And that has been my clinical experience, and every place I talk, I hear the same thing. So what do we know about marijuana use in the teenage brain? As with everything in the teenage brain, it isn't so good. Most of the data we have, because guess what? We haven't researched this stuff much. That's part of the problem with marijuana. Kids think it's a health food. You talk to a kid about marijuana, they say the same language. They say it's not as bad as alcohol. And the truth is, I don't disagree with that, but I think alcohol's bad, right? Are you more likely to kill somebody on the road using marijuana than alcohol? I don't know, actually. You definitely are impaired. I definitely don't think you should be driving. Are you likely to go out and murder somebody with marijuana? No, because it causes a lot of amotivation, right? These guys aren't getting off the couch to do anything. They're not doing extracurricular activities. They're not running. They're not doing their homework. I'm telling you that in a developing brain, any chemical that is going to disrupt normal development is bad. That's my bottom line. And so when marijuana gets legalized, potentially, if I can guarantee that nobody under 25 is going to use it, I actually don't care, quite honestly. If some adult wants to smoke marijuana a couple times a week because it helps them with their fibromyalgia or their, whatever, you know what? I don't care. I don't think of it as being much different than alcohol. The problem is everybody under 25. When people come ask me for their medical marijuana card, you know who they are? They're 21-year-olds who have anxiety and can't sleep. 100% of the time, that's who they are. And that's the group who really should not be having it. And Carla, my grade school nurse, texted me the other day, what's CBD oil and why is it in my school? And I'm like, cannabinoid oil? I know what that is, but why the hell is it in the school, right? So what did I do? I marched down to my local vape shop that just opened because I was pissed because I knew they were the ones who were selling it. And I'm like, you're selling this to 16-year-olds. And they said, oh, no, we're not. I didn't actually start that way. I said, tell me about cannabinoid oil and how do you tell people to use it? And so they then told me, I must not look like a doctor that day. And they're like, oh, we use it for everything. It cures cancer, it shrinks tumors, it gets rid of all seizures. You could apply it over your entire body. And I'm thinking, wow, this is where a lot of people are getting their medical advice from. So everybody has a vape shop or a head shop near them? You guys walked in there? Oh, you need to walk in. Let me tell you, it's fascinating. And it is where your kids are getting all their information. So it is a place, honestly, where you're going to just learn 1,000 different ways to use marijuana. They're there really to sell e-cigarettes, and we're going to talk about e-cigarettes in a second, but really it's about trying to get marijuana into people's bodies. But really what happens is people will use those vaporizers to ingest anything, to inhale anything. And the CBD oils that we're seeing, first of all, these are 16-year-olds. They don't have tumors or likely seizures. They're not applying it to a pain that they have. Probably they're vaping it, right? They're inhaling it. I have no idea what that does to the lungs. And it's certainly not intended to be used that way. And even these little 22-year-olds working at the vape shop were like, oh, I don't think you should vaporize that. And I was like, no, you probably shouldn't put that in your lungs. So the problem with the e-cigarettes, as you guys all know, you have no control over them. They are using them in your public school bathrooms. You don't know what's in their bag, right? I mean, have you guys seen what those things look like? They look like pens. I can't distinguish them. And you could put anything you want. They're odorless. They're not going to set off the fire alarm. And there will be no detection of its use in your school. Yet there are chemicals that are being put into people's bodies, and you don't know about it, and you can't seem to control it. It's very frustrating. Okay, top drugs used by 8th and 12th graders. You guys know this stuff already. On the 8th grade column, what is most prominent on both sides? Marijuana, we covered that one already. But it's the inhalants that really get our middle schoolers. And if you have a parent that you work with or a kid, you know, inhalants are bad for you. First of all, the high you get from them isn't much. It's sort of like you just feel dopey. And it actually, many of those things kill brain cells. It's not good for a developing brain. They quickly leave the inhalants because they realize they're not so hot and they can move on to better stuff if that's where they're headed. But in the vocational schools, for those of you who work in the vocational schools, you've really got to pay attention to the volatile gases kids are exposed to, because there's a lot. Automotive shop, there's a lot of stuff there. 12th graders, again, marijuana, and then pills. But I'm going to say that the pill thing is a horse well out of the barn, right? We are controlling pills a little bit better. Heroin's prevalence in our community is so great, and it is so cheap, and it's so easy to get that kids are just skipping the whole pill stage at this point and going straight to heroin. Pills are harder to come by. They're expensive. You know, they're $1 a milligram. Some communities are up to $2 a milligram. Most teenagers can't afford that. Okay, cigarettes. This is, again, happiness. This is a great data. I love this one. Cigarettes have plummeted. They're wicked expensive. Most people think they're gross, right? A lot of teenagers are like, oh, I would never smoke it, disgust them. But what are they using instead? They're doing anything with tobacco. Somebody said chewing, but they could be inhaling it, right? There's just a use of nicotine. And I don't care which way nicotine comes, it's an addictive substance. Nicotine itself is not harmful, right? But it's addictive. It's everything else that comes with it. And the truth is, we have no idea. We are not understanding the world of e-cigarettes enough to know really what it's doing to lungs and to children's brains. This data just came out from the CDC just a couple days ago. And what you see is, if you look at that bottom row, tobacco use in general, actually 2014 has gone up. And tobacco use in general is all the stuff that you're describing, other use other than coming in a pack of Pall Malls. E-cigarettes, look at that number. It's a regular cigarettes the way we used to know them, way, way down. But way, way up are the hookah pipes and the e-cigarettes. These are marketed to children. You guys know that. You see them. They're at the mall kiosks. They're like watermelon bubblegum flavor, and they're covered in glitter. They look like the covers for your cell phone. Like, why wouldn't an 8th grade or a 9th grade girl want that? This is just something, if you scroll the websites of people who use drugs like I do at night, I'm always like, one, I like to get my socks blown off, but this is just a description. Most of your kids who use drugs, how do they learn about them? Sometimes from their friends, but they learn about it from the internet, which is chock-a-block full with all kinds of information about how to do anything you want, how to cook anything you want. This is a question that somebody asked is, how could I vape my heroin, basically, right? How can I inhale my heroin, get a faster high? And then there's, 1,000 comments on it, like, oh, you could do this and you could do that, and it might ruin the mechanism. But this stuff goes on for days and hours and months. Like, how can I get more drug into my body in a different way? And again, when you're walking into a school with a little vaporizer that you're using in the school bathroom, no one will know that, right? Maybe a drug-sniffing dog could find it in a vaporizer, but I don't know if that could happen either. I don't know. Anybody trying to get rid of e-cigarettes in their school? Does anybody have a strategy out there? I'm telling you, this is our next problem that we haven't gotten our head around yet. Okay, we've covered some of this that was covered by others, but risk factors for alcohol and drug use, peers influence things. If your friends use, you're more likely to use. Norms favor use, early initiation. If schools seem like places where drugs don't matter that much, where there isn't constant conversation about trying to help you develop a healthy brain so you can achieve academic success, those are places where you're going to have higher drug use. Parents, if your parents are actively using drugs, they're popping pills all the time, or really your mom comes home and has a bottle and a half of wine, you think those kids don't watch that? Do you think that does not make them want to drink? That is normal behavior, and that's what they see. So let's talk about alcohol for a second. This is American data on how many of us drink. 1/3 of us drink zero, not a drop of alcohol, nothing. There's often a reason there, and so when people tell me they don't drink, my next question is, why don't you drink? Because sometimes it's, I just never developed a taste for it, but most often it's because my mom was a drop-dead drunk and used to hit me. Like, that's useful information. I needed to hear that one. So 1/3 of us drink nothing. 1/3 of us drink a little bit, a couple drinks a week. And 1/3 of us drink the rest of it, which is a lot. And in fact, the top 10%, it's actually the top 9% of us drink on average 7 to 8 drinks a day. That's a lot of alcohol. So when I said to you 7% of us are alcoholics, there's even more of us that actually have developed a very unhealthy relationship to alcohol. And you know, I just want everybody to pause, no hands in the air, but just ask yourself about your own relationship with alcohol. Those of us who work stressful jobs, that carry a lot of worry home with us, that have kids who concern us, it is often an early thought getting in the car of, I've had a terrible day, I can't wait to have a drink. And the moment I think that thought of, oh my God, I can't wait to have a drink, I don't get to drink, right? Because I'm clearly self-medicating for stress. And as I talk about this stuff more and more, my relationship with alcohol has changed. So risk factors for alcohol, drug use in the community, how available it is. And I tell you, it's available everywhere, and the stuff is running $3, $4.50 a bag. In the last few weeks, I've had guys come in, because I have a normal family practice where I take care of all ages, babies and 100-year-olds, and I also, in that mix, take care of any number of people with an addiction to a variety of substances. And they'll come in and be like, man, I found dope just lying on the floor at CVS. And I'm like, really? And they're like, yeah, it's so cheap now, it just falls out of people's pockets and they don't bother picking it up. So these are bags of dope that a 4-year-old could pick up. You think that's not going to kill a 4-year-old? It will kill a 4-year-old. It'll kill an 11-year-old who hasn't used it before. But this stuff is so available, it doesn't even matter if it falls anymore. This is one of the more important things I'm going to talk about. Do people use adverse childhood events, ACE scores, ever in your practice, in your school? Somebody does? Are you health education? You do? Are you social workers? Nurse. Wow. Okay. I love that you're doing that, because I tell you, more of us should be using ACE scores. And I'm going to talk about what that means exactly. But what you guys know is you could predict your 10% of your school that you're most worried about. You could make a list of your biggest worries out there right now. Biggest